Hello, everybody. I'm Dr. Matteo Forlini. I'm vitreoretinal consultant at San Marino State Hospital and in Ravenna Domus Nova Eye Clinic. And I'm telling you this story about a 60 years old female patient presented in a very particular way because the story of the eye is very long with many surgeries, starting in 1998. When she underwent excimer laser, PRK, to correct high myopia in both eyes. Then, after 20 years, in 2018, she developed cataract formation in the left eye. And so she underwent phacoemulsification with one-piece foldable IOL implantation in the capsular bag. Even if, during the surgery, a posterior capsular tear occurred. At that time, the surgeon decided to implant the IOL in the bag, even if a small posterior capsular tear was present. A year later, in 2019, the same surgeon decided to implant an ICL in the sulcus as a secondary piggy bag add-on IOL over the one-piece foldable IOL already positioned in the capsular bag. Then, in February 2022, the patient came to our clinic presenting sudden visual loss in the left eye after blown trauma with this ophthalmic scenario like visual acuity of 0.4 with a spheric addition of plus 13.5. So, of course, there was aphakia. Slit lamp, clear cornea, round central pupil, but ICL still positioned in the sulcus. So the ICL was still positioned there. IOP was high, 28 millimeters. And in the fundus, we saw the one-piece foldable IOL luxated in the vitreous chamber. Fortunately, no retinal detachment. So we had to proceed with the surgery in the left eye, performing pars-plana vitrectomy in order to catch the luxated IOL in the vitreous chamber. We started vitrectomy using 23 gauge instrumentations and chandelier 27 gauge. So you can see the IOL luxated in the vitreous chamber, one piece foldable IOL, as I said. So after central vitrectomy, we are using a triamcinolone to stay in the vitreous and to check if posterior hyaloid is already detached. Posterior hyaloid was already detached, so we completed central vitrectomy and we extended to the peripheral vitrectomy with indentation. You see, this is illuminated scleral indentation. It's very useful because I can indent with a special instrumentation. And thanks to this illuminated scleral indentation, it's much easier to see all the peripheral vitreous stained with the triamcinolone. So, as you can see, I'm completing the peripheral vitrectomy with vitreous-based shaving. It's very important to complete the whole periphery of the vitreous. And the last part is the vitreous surrounding the IOL. Why? Because I want to keep the IOL attached to the vitreous while I'm removing all the other sectors of the peripheral vitreous. Now, when I finished all the peripheral vitrectomy, I focus on the IOL. So I'm removing the vitreous surrounding the IOL. So now finally the IOL is free to move. And now it's the time of focusing on IOL removal. It's very important because you have to remember first to clean the vitreous. Now going to anterior chamber. Now I have to remove all the capsular remnants because the capsular bag was still there. As I told you, there was a small capsule break in the posterior capsule, and that's why the IOL fallen down. But the capsular bag was still there. So as you can see, with bimanual maneuvers, with forceps, I'm removing step by step all the capsular bag using vitreous cutter and crocodile forceps. And now prophylactic 360 degrees endolaser. And after endolaser, I'm preparing for IOL removal. But first, I have to remove the ICL. You see, ICL is still there. So this is ICL. I'm trying to catch it. I'm trying to, oh, unfortunately, ICL fell down too. So now I have two IOLs in the vitreous chamber, the ICL IOL and the one-piece foldable IOL. So now I have to remove both, of course. I'm starting with the one-piece foldable IOL. So grasping it with the crocodile forceps and taking it to the anterior chamber. Now I have two forceps in my hand and I'm enlarging the corneal wound. So now I'm just pulling the IOL outside of the anterior chamber. And one IOL is gone. Now back to the vitreous chamber to remove the second IOL. This is the ICL. It's very large, of course, but we know that it's very elastic, very foldable. So even if it's very large, it's possible to remove it through this pupil. As you can see, now the pupil is narrow because after all these maneuvers, of course, the pupil gets narrower and narrower. So it's even more complicated now with this narrow pupil. But little by little, also with bimanual maneuvers with two forceps, I can move the ICL in anterior chamber and take it out. So now the second IOL is gone. Now it's aphakia, and I'm preparing for the secondary IOL implantation with the iris claw retropupillary enclavation. I'm enlarging the corneal wound at 5.5 millimeters, and this is the IOL. It's important the vaulting. So now the IOL iris claw has to be the concavity up because I want to implant it retropupillary. So the concavity has to be up. I'm holding the iris claw IOL with the special forceps and putting IOL in the posterior chamber. And with the other hand, with the spatula, now I'm doing the posterior enclavation on the posterior surface of the iris. So that's it. Now I did the retropupillary iris claw IOL enclavation. Of course, I closed the corneal wound with the 3 stitches, nylon 10-0, and I'm removing the trocars, sutureless. And this is the end of the operation. The chamber is okay, and the IOL is stable and well enclavated in the posterior iris surface. So 1 month post-operation, in April 2022, the patient presented a very good clinical scenario. Visual acuity raised to 0.7 with a small cylinder of -2 at 160. So following the rule. A slit lamp, some decimate membrane folds, stable retropupillary iris claw IOL, round central pupil. It's very important to have a round centered pupil after iris claw enclavation. So we didn't have pupillary distortion. Intraocular pressure was good, 14 millimeter, using brinzolamide and timolol morning and evening. And fundus was normal. As you can see in the OCT, no macular edema. So take-home message of this case. In my opinion, iris claw IOL present many advantages to treat this kind of IOL removal and secondary IOL implantation. Advantages of iris claw IOL are fast surgical procedure. You can avoid conjunctival opening if you do a corneal wound. Iris claw IOL is fixated to the iris mid-periphery. That means minimal effect on the normal physiology of the iris or anterior chamber angle. And we have a low incidence of corneal decompensation, secondary glaucoma, or cystoid macular edema. As you can see, OCT was good, cornea was good. Disadvantages, maybe somebody can think it's a complex surgical technique, but actually after some learning curve, it's not so difficult to implant a retropupillary iris claw. Astigmatism can be an issue, especially if you do a corneal opening, because of course iris claw IOL is rigid, is not foldable, so you have to open at least at 5.5 millimeters. So you can induce some astigmatism, of course. And you can have the risk of pupil distortion. It's important during the enclavation to push the spatula through the iris tissue, following direction to the center, so centripet, not to the periphery. In this way, you can avoid the cat's eye, the distortion of the pupil, as you can see in the video that I show you. Thank you all for your attention.